Hi, everyone. I think we're going to get started. So I appreciate everyone joining us this evening for this very special webinar, Making Rash Decisions, How Dermatologists Think. My name is Kim Montanarello from VisualDx, and we have been proud to host these educational webinars throughout 2020, and of course, plan to do many more in 2021. Before I introduce tonight's presenter, I have a few housekeeping notes. We encourage Q&A. So to be sure to use that Q&A box, and we'll try to get to as many questions as we can. Also, this webinar is being recorded, and we will share with all the registrants. We do ask that you take the survey at the end to provide feedback and give us ideas for future topics. With that, I'd like to introduce our presenter, Dr. David Harker. Dr. Harker grew up in rural Alberta, Canada, and is a graduate of Brigham Young University and remains an avid Cougars fan. He dabbled in crop genetics in undergrad, helping to sequence the cotton genome before going to medical school at UT Southwestern in Dallas, Texas. After a brief stint away from UTSW to complete his intern year at Baylor University Medical Center, which is also in Dallas, David returned to UTSW for his dermatology residency, spending his final 6 months as chief resident of the VA clinic. He currently practices in rural North Carolina, where he lives with his wife and 3 young children. You can follow him on Twitter at Harker David. That's where I first came across his wonderfully engaging tutorials, and I'm excited for you guys to learn something tonight as well. So without further ado, Dr. Harker.
Thanks, Kim. All right, y'all, I'm excited to be here and talk with y'all about some dermatology. Let's see if I can get my screen share to work here. Is that working, Kim?
Yep, I see it.
Okay, perfect. Okay, well, I'm glad to be here. Grateful to VisualDx for hosting this, and really excited to talk with y'all about dermatology, a specialty that I think is really exciting and interesting and fun, but perhaps maybe a little underappreciated in the field of medicine. My only conflict of interest is that I'm on the advisory board for VisualDx. So let's get started. So, I've always felt like ever since I got interested in dermatology and started pursuing it, and then, did my residency training, and since I've been in practice, that dermatology is one of those fields that maybe doesn't get as much respect in the house of medicine as it deserves. There's lots of jokes about dermatologists. There was a whole Seinfeld episode about us. There's, people always say, well, just try a steroid cream, and if that doesn't work, try a fungal cream. And if I had $1 for every time someone tweeted at me that if it's a wet rash, dry it, and if it's a dry rash, wet it, and that's all there is to dermatology, I would have paid off my student loans by now. But one situation where I did find that we seem to get some respect as a field is when I was on consults. At UT Southwestern, where I trained, we have a pretty busy inpatient consult service, seeing a lot of very interesting and complex patients with a wide range of diseases. And often as the consultant dermatologist, we were critical in helping nail the final diagnosis for these patients and helping them get on the road to recovery. And it was during my time on the consult service that, I really started to notice that maybe, dermatology has a lot to offer in these settings, and the other physicians could recognize that. I remember as an intern, whenever I had to call a consult, that was sometimes the worst experience. You could just get eviscerated by grumpy hematologists or neurosurgeons, and it was just oftentimes an uncomfortable experience calling someone else, and you would feel nervous and apprehensive calling a consultant. But I never imagined that someone would feel that way about calling me. But you can notice sometimes, and I was, as a second-year dermatology resident, I had no seniority in the hospital, but these seasoned hospitalists and other physicians would be calling me for help with the patient, and they would stumble and fumble over their words trying to describe what the patient had to me. And it was just an eye-opening experience that, hey, there's a lot of opportunity for education, and that, I really feel like dermatology is under-recognized, underappreciated, and underutilized and taught in most medical curriculum. And so I hope I can help provide some insights and some lessons that will help all of us learn some things that can help us take care of patients. So one thing that happens a lot in dermatology is rash description is incorrect by other specialists. We notice. A lot of people just, if they see any red rash on a patient, they call it a maculopapular rash and leave it at that. And, that phrase has become so misused that it really doesn't convey a lot of meaning anymore. I really liked this short tutorial by Dr. Lipoff, one of the folks I've met through Twitter. a great dermatologist who, kind of explained this for us. I thought I'd read a couple of his tweets about this concept. He says, as a result of being misused constantly, the term maculopapular rash has lost any specificity in the house of medicine. And as such, we as dermatologists, no disrespect, generally ignore any use of it by non-dermatologists since it is most likely being used incorrectly. I think what bothers dermatologists most about using maculopapular rash for everything is that it suggests that the medical establishment does not put enough value on learning the exam of the skin. And I really agree with him on this point. Really, if someone calls me with a consult and says my patient has a maculopapular rash, it means essentially nothing to me at this point. There is a correct way to use that phrase, but because it's been misused so much, like I said, it doesn't really have much helpful meaning anymore. It really should be used to denote rashes that look like measles, or sometimes another way to use the word, or another word for maculopapular is morbilliform or measles-like. And rashes that appear like measles, like drug rashes and other similar reactions, are appropriate to use the word maculopapular to describe. But I think because rash description is not really emphasized in medical education, and maybe you get one lecture on it and then things move on and you never have to think about it again, that skill is lost in a lot of doctors. And I think it's an important skill. And why is it important? Well, describing a rash, even though we have images now that let you just send pictures to your friends and that might be dermatologists or to a consultant dermatologist, it's still important to know how to accurately describe a rash, because that means you're on your way to getting the correct diagnosis. Whenever someone says to me that, oh, all rashes look the same, especially if the doctor, all rashes look the same to me, I always think about this thought that I had once and tweeted that, it'd be similar to being on medicine rounds and a resident looking at an EKG and saying, well, they all look the same to me, and everyone just kind of moves on and thinks that's fine. And that's not fine in dermatology. I mean, not our rashes don't all look the same. And, I think a lot about, I like the Sherlock Holmes series. And, one thing that Holmes said to Watson was that, well, Watson, you see, but you don't observe. And I think that's really, in dermatology, that's a very applicable concept, that you can see a rash, but it's not the same as observing a rash and seeing the features that will help you make the diagnosis. So that's kind of what I wanted to focus on tonight in my talk with y'all. And why are dermatologists so obsessed with description? Why do we harp on it so much? Well, this Dr. Chen, another dermatologist on Twitter who I've learned a lot from, had a tutorial about this as well, and emphasizes a point here that I've harped on a lot, but that, for morphology of a rash, what the components of the rash are is everything to a dermatologist. That's how we build our differential diagnoses, and that's how we make our diagnoses in the end, oftentimes in conjunction with biopsies and histopathology. But if you correctly describe a rash, it means you've correctly identified the salient features, the primary lesion, the secondary features, the distribution, and all of those together help you figure out what the diagnosis is and what the rash is. So that's why we care so much. That's why you can't just call everything, it's a rashy rash and move on. Describing the rash really helps you start to build a differential. And so I'm going to kind of go over, just take things back to the basics here a little bit and spend some time reviewing these terms that you've probably heard in prior dermatology lectures and then forgot afterwards because you didn't have to use them much after that. But when you look at a rash, the first thing you should always try to do is identify what the primary lesion is. What's the actual process behind this rash? Because that will give you a differential. Different rashes cause papules than that cause macules. Oftentimes there is overlap. One rash can cause multiple different primary lesions, but it's important to try to figure out what those primary lesions are. We have some examples here from courtesy of VisualDx. So the one on the top there is the papules, the classically described purple polygonal pruritic papules of lichen planus. In the center, we have the larger plaques of plaque psoriasis, and on the bottom is a dermatofibrosarcoma protuberans, or what we call DFSP, which is a nodule. As you can see, it looks like it's kind of growing up from underneath and pushing up underneath the skin. And these are just some of the basic building blocks of dermatology in describing a rash. If you see papules, if you see plaques, if you see nodules or tumors, these all start to inform your differential diagnosis. So then we think about, and I also wanted to say, a concept that's not recognized often is that a depressed lesion is also a papule or a plaque. So if there's any change in elevation to the skin, either something you can feel that's elevated like a papule or plaque, or that's depressed, it also is called a papule or a plaque because it's a change in elevation or texture of the skin. So moving on to things where you can't feel, one of the dermatologists that I trained with as a medical student and a resident would say, if it's a macule or a patch, if you can close your eyes and run your hands across it and you can't find the lesion, that's a macular patch. So usually macules and patches are really referring to color change within the skin. On the left side here is the depigmented macules and patches of vitiligo, and on the right is a kind of reddish salmon colored patch of a port wine stain. So these are primarily color changes in the skin. They can be from vascular changes or pigmentary changes, but there's something that usually you can't feel. That's what defines something as a macular patch. And again, the diseases that make these are different than those that make nodules or plaques or papules. Moving on to other primary lesions, bulla or vesicles. The general cutoff in most textbooks is, if it's less than a centimeter big, you call it a vesicle. If it's bigger than a centimeter, you call it a bulla. But also the features of the bulla are important. Here you can see these are the tense bulla of bullous pemphigoid, which is different than the flaccid and easily ruptured bulla of pemphigus vulgaris. Again, just that's already telling you something about the histopathology or the pathophysiology of the disease. If it's a tense bulla, often that means it's a subepidermal bulla. Something's pushing up underneath the epidermis and separating it at the dermal-epidermal junction and causing that really tight enclosure around the fluid. Whereas if it's a flaccid or easily ruptured vesicle or bulla, the pathology is usually within the epidermis somewhere, so causing those keratinocytes in the epidermis to fall apart, and so the bulla is fragile and easily ruptured. On the right, another example of pustules, which are basically just pus-filled or filled with neutrophilic debris vesicles, and sometimes bulla if they get large enough. On the right side, this is an example of pustular psoriasis. Actually, one of my patients from my clinic. I got a social media consent developed for my clinic so that I could use some of my own patient images in my education. I always get verbal and written consent from the patients to use their photographs. And this is an example of pustular psoriasis. In my clinic, the poor patient was covered in it, but she's responded really well to therapy. And again, that's one of the things I really find gratifying and fun about dermatology is you literally see your patients get better. They come in with rashes like that on the right, and when you diagnose them and give them correctly and give them the appropriate therapy, you watch it melt away and their skin return to normal, and they're so happy. They're so grateful. The patients in dermatology are often very, very grateful and happy that you've been able to help them. So along the same vein here is on the left is an erosion, and on the right is an ulcer. Erosions are defects in the skin that generally don't go through the entire epidermis. Some of the epidermis is preserved. Whereas an ulcer goes all the way through the epidermis and into the dermis, and sometimes through the dermis into the subcutaneous tissue. So that's kind of the difference between an erosion and an ulcer. And again, different diseases cause different levels of pathology. On the left is pemphigus foliaceus, which is a very superficial process. The split is up high in the epidermis, whereas on the right is a pyoderma gangrenosum, commonly misdiagnosed entity that has very deep. Usually the pathology ends up being very deep as it burrows into the epidermis through the dermis and with this neutrophilic infiltrate. The example of pemphigus or pyoderma gangrenosum, there's a good example where you can have mixed morphologies. If you notice in that picture, there is an ulcer with the classic violaceous and undermined borders, but then along the periphery of the ulcer, you can also see some pustules. And an example here where there's mixed morphologies, mixed primary lesions, but again, when you correctly identify both of the primary processes going on together, that can put things together and help you realize or help you start to build a differential and figure out what the diagnosis is. So after you've figured out what the primary lesion is, you can start looking for secondary features. So the secondary features here that's exhibited in these two images is scale. And there's different types of scale. Not all scale is the same to a dermatologist. So on the left, we have the bran-like or pityriaciform scale of Pityriasis rosea. It's very flaky and wispy, and it's pityriasis is Greek, I think, for bran, so like the flakes of bran. And on the right is what's referred to as the micaceous scale of psoriasis, the silvery white micaceous scale that looks like you can just kind of flick it off in layers like the rock mica. And again, these indicate different disease processes and trigger different differentials in the dermatologist's mind when we see these. You look at if you see scale like that, you're thinking more about things like psoriasis. And if you see scale like on the left, it leads you down a different pathway. So even after you correctly identified the primary lesion, thinking about the secondary features goes a long way in helping you correctly build a differential and figure it out. So again, more things to think about, more features to describe rash. Here is erythema versus purpura. So erythema generally when people say erythema, they think that's equivalent with red in the skin, and that's not really true to a dermatologist. To a dermatologist, erythema means blanchable. So if you press on the affected skin, you can push that color out, and it will temporarily blanch, and then release the color returns. So erythema often is red, but there are different types of erythema, different colors of erythema. There's the bright red erythema of erysipelas, which we have on the left here, or there's the more violaceous erythema of dermatomyositis, which I have some pictures that we can see later. But again, whether it's erythema or not means blanchable, and then the color of the erythema and how well defined the erythema is, like you can see here, the very well defined bright red erythema of erysipelas is important. On the right, we have what's called purpura. Purpura just means that it does not blanch if you press on it, and usually is because there's been red blood cells that have extravasated out of the cutaneous vasculature into the surrounding skin tissue. And so if you press on it, the color doesn't go away, because the color change isn't just from dilated blood vessels like erythema, but it's actually a problem in the pathology. There's some kind of pathology with the vessels, and blood has leaked out. This is an example of leukocytoclastic vasculitis in dermatology. When we see this image and we think about palpable purpura, meaning that it's something you can feel. Again, purpura can be macular or it can be palpable. And palpable purpura has different diagnostic implications and a differential diagnosis associated with it than macular purpura. Same with inflammatory or non-inflammatory purpura. So there's all of these things, all of these fine details that dermatologists harp on and nerd out about, all are actually important in helping you think about what the patient might have. So here again is just talking about erythema, both different shades of erythema, and then remembering that erythema can look different in skin of color and can be difficult to, it just looks different. In Caucasian skin or white skin, erythema is usually not hard to pick up. In skin of color, it can be more subtle, and instead of looking red, it may look a little more purple or dusky, and that's just how it looks in that skin type, and it's important to know that. There's been a big push lately for education to emphasize that dermatologic manifestations look different in skin of color, although this has been a push for a long time. This isn't a new movement. There have been whole textbooks written about this before it's become a sort of popular or vogue topic these days, but one that we all need to spend more time learning about, because images in dermatology and in medicine there's often underrepresentation of skins of color to show the examples of these diseases. But on the left is both of these actually are dermatomyositis, just in different skin types. So you can see that what's classically described as the violaceous erythema, or violaceous just means kind of light purple or lilac light. As you can see on Caucasian skin, looks different in African-American skin. And here is an example of the kind of crusted erosions of impetigo. So again, sometimes when you just look at a patient and you see what's on their skin, you have to try to infer or decipher, well, what actually is the primary lesion? Is it what I'm seeing right now? Because when you see these ruptured, or you see these crusted erosions, you have to think, okay, what led to these? And if you look at the morphology, you can see the round edges of these, how they're sort of becoming polycyclic, or kind of rings joining together or coalescing into these larger rings with these eroded bases. These were all vesicles and bulla that have since ruptured, coalesced and ruptured. And so the primary process here is really, impetigo is bullous impetigo is a vesiculobullous disease. But lots of times you don't see intact bulla because they're so fragile. The pathology in bullous impetigo is in the very top layer of the epidermis. And so the cleavage plane there is very superficial, and these bulla are easily ruptured. And so this is, just a classic image. You might see a bullous impetigo where the bulla have all ruptured. Even common diseases like, impetigo is very, very common, but I commonly see this misdiagnosed in my own clinic. I've had referrals to patients that I've seen where, they were told by other healthcare providers that, oh no, this definitely isn't impetigo, and that's exactly what it was. So even basics like this are important, I think, for all of us to take some time to look at and learn about, so that we can help patients. There's one of the big reasons I think is important for other doctors and healthcare providers to learn about dermatology is that dermatologists are relatively rare as a specialty. We're not that many of us in the country or in the world, but dermatologic disease, on the other hand, is very, very common. And so I think it's important for all doctors, any doctors, nurses, nurse practitioners, physician's assistants, anyone who's involved in taking care of patients and seeing patients in clinic should have at least some familiarity, I think, with dermatology, because people are always going to, pull up their sleeve and say, oh, can you look at this rash? Or it's just so common and easy to ask about, or to see dermatologic conditions. And they're very, very common, but unfortunately, I think knowledge of how to diagnose and handle them is not. So once you move past sort of the primary lesion, the secondary features, you can take a step back, get more like a 30,000-foot view and say, okay, how are these primary lesions grouped, or what are they doing? What's their relationship to each other, or what's kind of a global pattern for them? So on the upper left there is kind of the grouped vesicles of herpes, herpes simplex virus. I've diagnosed a lot of herpes just in my short career so far, and it often is a surprising diagnosis to the patient because herpes has a wide spectrum of manifestations that can show up on any cutaneous surface, not just in the classic locations like the lip or in the genitals. But it always shows this classic morphology, or usually this shows this classic morphology of these grouped vesicles and pustules that are sort of starting to clump together on an erythematous base. So that's when you see that kind of clustered, sometimes even if it's not herpes, they may call it a herpetiform arrangement. When you see clustering like this, that's another descriptor used in dermatology. In the middle is, you can see these linear configuration of these papules, these sort of flat-topped whitish papules. The linear configuration here is from a process called Kebnerization, which means that the lesions have developed in sites of trauma. So scratching here has induced the formation of new papules along the axis of the scratching. This is a condition called lichen nitidus. But when you see those papules in isolation, especially when you take a step back and you can see the linear morphology of some of these streaks of papules, that again is an important clue that helps you figure out the diagnosis. On the right, this is another patient from my clinic with erythema annulare centrifugum, or EAC, very nice annular lesions that are starting to coalesce into larger plaques. But you can see they have this really nice annular or ring-like appearance to them. Annular is a word that's used a lot in dermatology. It just means ring-like. And in this case, in contrast to tinea, the scale follows behind the edge of the lesion. So again, secondary features in scale and paying attention to details being important in helping make the diagnosis, because tinea or ringworm, classically the scale is leading the edge of the lesion, whereas an EAC or erythema annulare centrifugum, it may be trailing behind. So just another example of using those secondary features to help us figure this out. Interestingly, this patient's RAS seemed to be triggered by eating blue cheese. This is one of these random facts that you learn in dermatology residency, that EAC, although it's associated with lots and lots of things, has been reported to be associated with blue cheese ingestion. And this patient's rash got a lot better when she stopped putting blue cheese on her salads. Go figure. And so other kind of global patterns you have to look out for, or just think about kind of the arrangement of the lesions, how they're grouped. So on the top right, is the acral distribution, which acral really means, like, people think about acral, they think about hands and feet kind of far away from the center, but it even includes like the nose and the ears in some textbooks and some descriptors, but basically away from the center. So the acral distribution of erythema multiforme, which also palms and soles as a whole, another differential in dermatology. If you see a rash just on the palms and soles, that triggers something in a dermatologist's mind. On the bottom left, there is the photodistributed rash of polymorphous light eruption. You can see the rash is primarily in areas that are often exposed to the sun, backs of the hands, the V of the chest. A tip for photo-exposed rashes is often spares kind of like right underneath the chin, which is usually shielded from the sun, things like that. On the next image over there on the top is the seborrheic distribution of really bad seborrheic dermatitis, or this could even be considered like SIBO psoriasis, which we think about as not being on a spectrum between seborrheic dermatitis and psoriasis. But a seborrheic distribution makes you think of certain diagnoses too when you see something that involves the scalp, the eyebrows, the ears, behind the ears, around the mouth, the chest, even the armpits and the axilla and the groin can be considered seborrheic. So seeing rashes in those distributions also starts to trigger a differential in your mind. And the bottom there is what would be like an intertriginous rash, or a rash that's in areas where skin rubs together. This is a classic image of extramammary Paget's disease, which is a relatively rare disease, but one I think, again, it's important for everyone to be aware of, that we should be aware of these kind of don't miss diagnoses in dermatology. I've already diagnosed extramammary Paget's just here in my own practice in rural North Carolina that had been misdiagnosed as a fungal infection. So again, just another example of where, dermatologic education is just lacking in general. And that's one of the things I really like to do, is try to help non-dermatologists learn about dermatology. That's one of the things I like to do on my Twitter account. I use images from VisualDx and from other online sources, and now from my own clinic, to try to help everyone learn about dermatology. So after you've taken all of these different features, you have the primary lesion, the secondary features, you've tried to figure out the arrangement, what's their relationship to each other, are there any global patterns that this rash is making? It starts to help you put it into what dermatologists call reaction patterns, which are reaction patterns are just kind of the overall look of a rash. Like a papulosquamous refers to papules and plaques that are scaly and coalescing. It's a papulosquamous differential. And when you see a papulosquamous rash, something that you can group into that reaction pattern, automatically in a dermatologist's mind, it's like there's a drop-down menu that folds out and shows, okay, well, these are the rashes that it could be. And then you try to use secondary features and other clues to help you tease it out. Another example here is vesiculobolus. So both of these are lists of differential diagnoses that were from a lecture that I've had in medical school. One of the, I think we only had 5 or 6 dermatology lectures in my medical school curriculum, but this was one that really stuck out to me, and I liked this concept of these reaction patterns. And if you see this, here's a differential you should think about. So just included these here as an example. There's a few main reaction patterns in dermatology, but this concept that after you put all the features together from looking at a rash and describing it correctly, that's when you can start to build a differential just based on that. So I will acknowledge that a lot of dermatology, especially for seasoned dermatologists, is pattern recognition. After a while, dermatologists don't spend as much time, trying to tease out the finest features of every single part of a rash that they see. Sometimes you see a rash and you immediately know what it is. The reason I have a picture of a moose up here is that you really have to see a moose once to know that it's a moose. After you see a moose, every moose you see after that, you'll be able to immediately identify as a moose. It's such a unique thing. And there's a lot of dermatologic diseases and conditions that are like that. Once you see a classic nodular basal cell, you'll always recognize a classic nodular basal cell going forward, or classic plaque psoriasis, discoid lupus. There's just some rashes that, when they fit their classic patterns, are just spot diagnoses, just instantaneous, immediately from pattern recognition. And there are some things that are like that. And that's how dermatologists sometimes look like wizards when they walk into a room and diagnose a patient within seconds. And that's also why, and going back to the earlier point about why physical exam and description is so important, that's the dermatologist, the physical exam is king. That's how we make our diagnoses. The history is secondary, sort of opposite to what you're taught in medical school, where they talk about making the history and then the physical, and I was told in medical school that you could make the diagnoses of a patient with a well-conducted history 80% of the time. In dermatology, it's the exact opposite of that. We really rely on the physical exam. Almost every new patient that I see in my clinic, I ask them just to change into a gown so that I can be looking at their entire skin surface while I see them, because I need to be looking at what's going on. That's what's helping me build my differential. The history is providing supporting clues and evidence to help me figure things out. But most of the time, I've established the diagnosis just by what I'm seeing. And the way I usually conduct my exam or my encounters is, while I'm talking to the patient, I'm examining them at the same time. It's not a sequential, history and physical like I was taught in medical school. I'm moving the gown, I'm looking at their skin, looking through their scalp, looking at their face, looking at their back, their arms, their hands, looking at the bottoms of their feet. I'm looking at everything, all their skin surface while I'm talking to them. And that's how I'm making my diagnosis. And because we rely so heavily on physical exam, eventually there are many diagnoses that we can make on site, and it's just like seeing a moose. Now, occasionally there are diagnoses that are trickier to differentiate just by looking at them. I mean, if you looked at these two snakes, would you be able to say which is venomous? Maybe some snake enthusiasts out there will know immediately, but when I was thinking of this example, I didn't really know when I pulled up these two images. But the one on the left is a coral snake, which is venomous. The one on the right is a rat snake, which is not. But without knowing that beforehand, it may be tricky. And you look at this and like, well, which of these is a dangerous snake? And sometimes when you see a patient with a rash, it's like that. Which of these rashes is a dangerous rash, or is this a dangerous rash or isn't it? It can be hard to tell. Benign rashes can mimic bad ones and vice versa. And so that's when getting down to the basics again and the finer points of describing the rash really helps you figure it out. Just like if you know a lot about snakes, you could dissect the finer points of what these snakes look like to figure out which one is venomous and which one is not. So kind of a corollary example to this, which of these two rashes is syphilis? One is syphilis, one is not. One is completely benign and will go away on its own. One you definitely need to know about, because if it's untreated, will progress to bad long-term outcomes for the patient and potentially more people becoming infected. So which one of these is syphilis? Well, one on the left is a patient from my clinic who actually just had pityriasis rosea, a little bit of atypical distribution for it, but that's what we ended up having, pityriasis rosea. Where on the right is secondary syphilis. So sometimes the rash is hard to say just by looking at it. And that's when we have to try to rely on some secondary clues, some history, being careful about our exam, and then ultimately, obviously, biopsy is a big part of making diagnosis in dermatology. in the patient's case, in my clinic, I found his Herald patch here on his thigh, which was reassuring to me that this was Violatious Erythema, and the rash did resolve on its own. I did a biopsy just to make sure I wasn't missing anything, but that's just a nice case of Violatious Erythema. So as I alluded to earlier, dermatologists do a lot of biopsies. The skin is a very easy organ to sample. And because of that, dermatology is sort of in a unique position where we learn a lot of histopathology in residency because dermatologists have such a close relationship with their pathologists and are constantly leaning on their pathologists to help them make diagnoses. I've said that behind every good dermatologist is a great dermatopathologist because really they really help us make important diagnoses all the time. And in residency in dermatology, we learn a lot of pathology. I think it's something that's not really realized, and I didn't really realize it fully before I got into the field, but we learn a lot of histopathology, a lot of dermatopathology, and it's important because it helps us understand what our dermatopathologist is trying to say to us when he or she sends us the reports from the biopsies that we've done. And it's important because a description of a histopathologic finding by itself does not a diagnosis make. There are some things that you can see as one-offs in the skin in a biopsy, and others that are critical to making the diagnosis, and that's where what's called clinical pathological correlation comes in, or what we call CPC, where you have to really make the diagnosis by integrating clinical findings on the exam with what's found under the microscope. And this was a really interesting case from my clinic. This patient came to me and had this, this linear, scaly plaque on the back of her right leg, and said she'd had this for her whole life, and I'd always just been told she had dry skin. She also had hyperkeratotic and corrugated plaques over her ankles bilaterally, and I just was looking at her rash and said, this isn't just dry skin. There's something else going on here. Linear configurations are another important clue in dermatology that help us build differentials. So I did a biopsy and it came back as this is actually the actual histopathological image from her biopsy, showing a finding called epidermolytic hyperkeratosis. But as I mentioned earlier, a biopsy finding on its own doesn't make the diagnosis. So you can get changes to epidermolytic hyperkeratosis just in random lesions, and it doesn't always mean anything important to the diagnosis. But in her case, the combination of epidermolytic hyperkeratosis along with her rash really made it clear that she had a condition called a mosaic epidermolytic ichthyosis, a rare genetic condition where she just has some of her cells have been affected with this mutation, but not her whole body, and that's why her whole body isn't covered in the rash. When we see patients like this, it's important because if they have a mutation here in the skin, in that what's called following the lines of Blaschko, which are the developmental embryonic lines of skin development, have sort of these kind of wavy S configurations over a lot of the body. When we see that, an involvement of a rash in that distribution that's isolated to there, especially one like this, could mean that she carries the mutation within her ovaries and her eggs, that she can have the risk of passing on the full-blown disease to one of her children. In her case, fortunately, that wasn't none of her children were affected, but it was just I thought this was a really good example of where, if you just do a biopsy and if you have a biopsy finding without the full context of the case, without seeing the rash and knowing the history and seeing the primary lesion and the morphologies, you won't necessarily make the diagnosis, or you could be misled into making a diagnosis that's incorrect. So again, it may just seem like, well, why can't the dermatologist just do a biopsy and that would just, always tell us the diagnosis? Well, you have to take a biopsy, and it's kind of like any other lab test or study that we perform. You have to know what to do with the results when you get them. And the integration of clinical findings with pathology is a really critical part of making a lot of dermatologic diagnoses. Not all rashes need to be biopsied to be diagnosed. There's a lot of dermatologic diagnoses that are clinical, or they could be diagnosed with bedside tests like KOH preparations. I've diagnosed a lot of tinea since I got here, and even scabies from KOH preparations. And so those are all adjunct tools that help a dermatologist link up what we're seeing on the skin with what we expect to find under the microscope. So I thought I'd spend a minute here just kind of reviewing or talking about some resources that I really like that I think are really helpful for the non-dermatologist who wants to learn more about dermatology. The American Academy of Dermatology has a really nice and free, what they call basic dermatology curriculum on their website. It has several modules, PowerPoint lectures that you can go through, organized by topic and alphabetical. And it's a really good resource if you're just looking for somewhere to start, where to brush up on your dermatology, because maybe you're a family medicine physician or PA practicing in a rural area that doesn't have easy access to a dermatologist, and you want to hopefully be able to at least get patients in the right direction or help them on your own, that's a good starting resource. DermNet, a website ran out of New Zealand, is free and is amazing. Has a lot of images on it, a lot of articles written by dermatologists, and it's a really easy, fast sort of point of care resource that I've used in residency and continue to use. It also has an atlas, or has a library of images that you can just browse and search by image or by disease to see examples of those conditions. And then I think if you're really trying to get serious about learning dermatology, it's important to look through atlases. This is just kind of an example of a classic, really old atlas that I looked through when I was studying for my boards. But going through atlases is important in dermatology because, you know, the eye can't see what the mind doesn't know, and you have to expose yourself to a lot of images, a lot of different pictures of rashes in different skin types, different morphologies. Some rashes are very polymorphous and can look in many different ways, like syphilis. And so exposing yourself to all the possible ways that rashes can manifest. And really, if you look at lots of images, it's like you're seeing lots of patients. You're having the benefit of seeing a bunch of patients that you actually didn't see, training your mind and your eye to recognize features that help you make the diagnosis. So getting a good atlas and going through images, I think, is critical. And then obviously, you know, the company that I work with, that I teamed up with, VisualDx, who's hosting this webinar. I mean, I think even before I had any relationship with them, I thought they had an amazing resource, and I used it all the time in residency. If you're in medical school or residency or working in an academic institution, it's worth looking into, just see if they have an academic subscription, because it's a great resource for point of care that helps you build differentials, that helps you see what rashes look like in different skin types, and just has a huge library of amazing images that can help you learn about dermatology. So those are kind of some go-to resources that you can try if you're wondering, okay, where do I need to start? Another thing I'd recommend is getting on Twitter. I mean, I've learned a lot on Twitter. I've had a lot of fun on Twitter, made connections with lots of people that I never would have met otherwise, been exposed to experts within my own field, and I've been able to just like send them direct messages about questions that I have, about cases, about dermatology. It's a huge resource, and there's a lot of dermatologists that are pretty active in education on Twitter. I try to be one of them, but there are several others. This is not an exhaustive list, just some examples of ones that I kind of engage with a little more frequently that produce amazing content, and I'd highly recommend just getting on Twitter, really just to learn from medicine. The medical Twitter community is great. There's a lot of good people out there with a lot of opportunity for education and collaboration and networking. So if you're not on Twitter yet, I would really strongly recommend it. I've been on Twitter for a few years now, and it's been a phenomenal experience. I've learned a lot, connected with a lot of people, and you know, you can come say hi to me on there. I think it's a good resource and a good free thing that all of us in medicine should try to get on, both to learn from and then also to try to be responsible medical professional citizens in battling misinformation online. And so the last point I wanted to make is just a kind of a brief story from my residency experience. This was a case that I talked about on a podcast I did for Figure 1. So I have consent from the patient to discuss all the details. I didn't have any images that I could use for today's presentation. So this is just a representative example from a recent case published in the New England Journal of Medicine of the diagnosis that this patient had. But I was on consults, inpatient consults as a resident, and the way it worked when I was there was we would take turns, usually a couple residents on together, and we would take turns holding the pager 1 week on, 1 week off. Because when you have the pager, I mean, it's 24-hour call, it could go off anytime. So I was at home on, I think, a Thursday night, got a page at about 8:30 for a new consult from the urgent care clinic that was associated with Parkland, the hospital where I did a lot of my training. And the consult reason on the pager just came up with a one-liner, you know, it said, you know, a young man with a new rash, concern for porphyria. I thought that was pretty interesting. Porphyria is a pretty rare diagnosis. So I was like, wow, I think this patient has porphyria. That's interesting. I better go check it out. So I opened up the, you know, Epic and looked on the EMR. They had pictures already uploaded, which I will say, if you're ever going to consult a dermatologist, please put photos in the chart before you call them. It's very helpful. So they had photos in the chart. And when I looked at them, I immediately knew this was not porphyria. I mean, it looked a lot like the images that I have here. And it was in a completely different diagnostic category because of the primary lesion. I mean, porphyria is usually grouped in the vesiculobullous category of diseases. This is nodules and tumors and plaques, completely different morphology and a completely different differential diagnosis. And when I saw it, I was very worried for lymphoma. I mean, when you see kind of these deep purple nodules in the skin, you're thinking about lymphoma, you're thinking about leukemia cutis, and I mean, none of them are good diagnoses. And this was a young man who had been, you know, having weight loss, fevers, night sweats, and the rapid onset of these lesions all over his body. I mean, this was not porphyria, this was something else. And I had that differential already in my mind just by looking at the picture before I'd even seen the patient. And I showed the images to my attending before I went in to see the case. And he said, yeah, I mean, I agree with the differential, but I also think it could be this thing called blastic plasmacytoid dendritic cell neoplasm. It's like, what? Okay. And he sent me some pictures from an article that he'd read about that case. And yeah, they did kind of look like that. I went in, I saw the patient, I did biopsies at bedside. I recommended the primary team call hematology immediately or oncology to get them on board with this case. And that's what he had. He had blastic plasmacytoid dendritic cell neoplasm, a really rare hematologic malignancy that really likes to show up in the skin very commonly and has this kind of classic appearance. So another example of just when this is an example, maybe to my attending was sort of like a moose, when you see it, you just know what it is, but definitely one that needed biopsy and correlation of the clinical with the histopathology to make the final diagnosis. And I think it was just sort of a cautionary tale to me that, I really feel like, what if there had been no dermatologist to consult for this patient? What if the only person who had seen him was that urgent care provider and said, well, maybe this is porphyria. Porphyria isn't necessarily, if it's porphyria cutaneous tarda, not necessarily a urgent life-threatening illness that needs to be worked up immediately. Maybe they would just send them with an outpatient referral to see a dermatologist. But this is a disease that could progress rapidly and is a medical emergency. This patient needs urgent attention. And so I think just another example of how dermatologic education is really sparse and inadequately taught in most medical curriculums. And I think if this is anything, just maybe a story to help encourage you to do your own, to try to learn as much dermatology as you can with some of the resources that I mentioned, and then being on Twitter, because there's a lot of us out there that want to help learn so that we can all take care of patients together. That's all I really had. This is just a picture of a tree that I thought was cool in North Carolina. We've been doing a lot of hiking and getting outdoors here in the beautiful rural North Carolina environment here. And during COVID, we're just trying to stay away from other people, and hiking and being in nature is a good way to do that, with sunscreen and a hat on, of course. But that's really all I had. So I'm glad that I could be here, and thanks y'all for attending.
Thank you so much, Dr. Harker. We do have a few questions that have come in, and of course, anyone can feel free to use the Q&A because we have a few more minutes that we can do. First question, if you can run your hand over it and not feel anything with eyes closed, is it macule or macule-papule?
So papule implies palpability. So the reason that there's, maculopapular as a descriptive term of like a morbilliform rash or a measles-like rash is because it has both morphologies in it. It has some macular components that are just erythema that you can't feel, and it has some papular components that are elevations or papules so you can feel them. So if you close your eyes and you can't feel anything, that's a macule. If it's small or less than a centimeter is the general cutoff. And if it's larger than a centimeter or kind of just a bigger area, then it's a patch. So macules and patches. Again, both usually denoting just color change in the skin because you can't feel it.
Okay, next, is there such a thing as scaly macule, a flat lesion that is rough on the surface but is still able to be felt with the eyes closed?
Yeah, so this kind of gets into the weeds a little bit with dermatology. I mean, there will be some people that say if you can feel it at all, then you shouldn't call it a macule. But I mean, for example, some conditions like tinea versicolor really sometimes just produce completely flat lesions that have a little bit of scale on the top of them. So the main thing you want to think about is if you can feel scale for something that's palpable there, then there's some process going beyond just, a pigmentary or a vascular alteration of the skin. There's an epidermal process or a dermal process because there's some elevation or change happening. So it's just if it's a macular, pretty flat lesion that has scale on top of it, then some people would probably just call that like a thin papule or a thin plaque. But if it has palpability, then you're thinking about some kind of, especially if there's scale, you think there's an epidermal component, something happening, some pathology within the epidermis.
And someone asked, wanted to make sure that they heard you right. If it is depressed or raised, is it a plaque?
Yeah, papules and plaques, really any elevation change in the skin. So like a depressed plaque of morphia, a scarring disease, will cause these indentations within the skin, or paniculitis can cause indentations in the skin. And so those are still papules and plaques because you can feel it. There's a change in the contour of the skin, whether it's a depression or an elevation, both are referred to as a plaque.
And I'm not sure if this is your area of expertise, but someone was hoping that maybe you could describe that patho slide that you had a few slides ago.
Oh, I mean, I'm not a dermatopathologist. I mean, we spent a lot of time learning dermatopathology in residency, but the epidermolytic hyperkeratosis, I mean, epidermolysis, you can just kind of in the word like destruction or lysis of the epidermis. And then hyperkeratosis means thickening of the stratum corneum. So if you put those two words together, epidermolytic hyperkeratosis, I mean, you can see here, it looks like the epidermis, there's like destruction kind of going throughout that whole layer there. And then there's hyperkeratosis, there's a thick stratum corneum. So that's what that combination of those two words together means.
Great. And then looks like this is the last question. Is there a serious dermatological condition that you've missed or seen a delayed in primary care that you would suggest providers really learn more about?
I mean, I think there's been a few times now where I've just seen cases where diagnosis was delayed because really probably an exam just wasn't done. A common area I think that happens is where if a woman complains of a vaginal complaint, like just itching or burning down in the vagina, I think a lot of providers may be uncomfortable to examine that area, or maybe the patient's uncomfortable having that area examined, and so they just write a prescription empirically and then kind of just judge it by symptoms to see if it gets better. But there's been a couple times now just in my practice here where I've seen really bad cases that have been missed, like one really bad case of lichen sclerosis, which is a scarring condition down in the vulva that was missed probably because no one had just really looked at it until I did. And the same with the extramammary Paget's diagnosis, just a case where, I mean, maybe they did look, but I think a lot of times it's important to do a physical exam and actually look when there's a complaint, and then having your eye trained to know what to look for to make you think like, oh, this is a bad thing I shouldn't miss. And like extramammary Paget's or lichen sclerosis are examples of diseases that I really think shouldn't be missed. Like those should at least be in the back of any healthcare provider's mind for a rash down in the vulva.
Okay, we got two more questions. Would it be incorrect to call something atrophic macule if there is indentation?
If it's indentation, then you call it like a papule or a plaque.
And then someone said, I came in late, but so I may have missed this, and I'm not sure if you covered this as well, but in your expertise for common rashes due to atopic dermatitis or psoriasis, is topical treatment hindered because it can't permeate well enough through the epidermis?
You cut out a little bit at the beginning of that question. Sorry, Kim.
In your expertise for common rashes due to atopic dermatitis or psoriasis, is topical treatment hindered because it can't permeate well enough through the epidermis?
I mean, yeah, you want to get the medicine to where it needs to be. I think, I don't know if I totally understand the question, but if there's a lot of scale or if the skin is very thick, it can definitely make it difficult for topical treatments to penetrate. Like if there's really lichenified or thickened skin in chronic atopic dermatitis or a thick untreated plaque of psoriasis. So using emollients or keratolytics like ammonium lactate or salicylic acid to help break down the skin so that the medicine can penetrate is something we use sometimes to help the medicine get to where it needs to be.
Great. Well, I think we'll end it there. Again, I want to thank you, Dr. David Harker, for this great presentation. I'd also like to plug visualdx.com/events, which is where we keep all these upcoming webinars that will be going through 2021 and beyond. So thank you all for joining us. And again, make sure you fill out the post survey as you leave here today, and hope everyone has a nice, safe, and happy holiday season. Thank you all so much. Bye.